Good evening, Professor. Take your go to. How are you?
How are you?
Thank you.
Welcome, Professor Mura.
Good morning.
See you. Good to see you. Early morning for you.
Yes, yes. I am in Mexico. It's 4:30.
Oh,
4:30.
thank you. Thank you for getting up so early for the meeting.
Yes, yes, yes. Ohio gozaimasu, sensei.
Nice to meet you.
Yeah, nice to meet you too.
I think Dr. Sampath is having some problems. I'll just get it done. Then we'll start.
What about Professor Stefan?
Professor Stefan is in the meeting. He said he will join. I'll just message him.
This is also being transmitted in YouTube live in the NSI channel. Dr. Dwarka?
Yeah, I'm just waiting for Dr. Sampath. He has joined, but he's apparently having some problems with his joining the video. Professor Florian also has joined.
Yes.
Welcome, Professor Florian. Thank you.
Welcome, sir.
Good morning. You have audio out, Stefan.
Now,
Now,
okay, it's okay. I'm in the workshop organized by Cerebrovascular Committee, which you are part of, here in Bucharest, in Romania. That's why I just entered. I finished my presentation in the workshop, and I will join them after my presentation. So apologize for not being from the beginning here and for leaving you, but I'm glad to be here. And when you are ready, I can.
Yeah, I think we can
Hello,
start now. Dr. Dandapani, do you want to start?
Yeah, okay. Sir, welcome, Professor Sampath, sir. How are you? Sir, you're muted.
See, it takes little time. You
Yeah, no
start.
problem.
Next time you start.
Yes, sir. Welcome, sir.
Okay, fine.
So good evening, everyone. I think it's good morning for Professor Mura, and for
Yes.
others, it's a pleasant good afternoon. So on behalf of the Neurological Society of India, myself, Dr. Dandapani, and the chair, Dr. Dwarkanath, and other Professor Sampath. So we welcome each one of you today for the webinar. Actually, this is going to be the last webinar of our term. So we are glad that we could have eminent speakers in their own field, like Professor Takeo Goto, Professor George Mura, and Professor Stefan with us today. So this will be also transmitted live in NSI YouTube channel. So we welcome each one of you, those who are there in Zoom and those who are seeing this in YouTube. So we welcome you, each one of you. We are very grateful for all the eminent speakers to have spared their precious time for this. So all of our eminent speakers, they don't need any introduction at all. So Professor Takeo Goto is a very eminent and fantastic endoscopic surgeon from Osaka, Japan. So I think he doesn't need any introduction. So first we would hear from him. So over to you, Professor Goto.
Thank you, Professor Dandapani, for kind invitation. At first, I will share the slide. Okay, so can you see my slide?
Yes, we can see your slide.
Okay. So my topic is endoscopic various kind of the approach for resection of the skull-base tumor. Today, I will talk about the endoscopic enonasal and endoscopic keyhole approach. Recently, the endoscope can offer the clear view around the deep city area. So this instrument is very useful for resection of the skull-base tumor. So today I will present my endoscopic and nasal approaches and also endoscopic keyhole transcranial approach. At once, I will introduce our endoscopic and nasal approach. Of course, I'm the skull-base surgeon, so I frequently use a classical transcranial approach for resection of the skull-base tumor. But if the region located pure central skull base, in such situation, endoscopic and nasal approach very useful. For example, this is a craniopharyngioma. In case of the craniopharyngioma, if we observe the lesion through the endoscopic endonasal approach, we can directly access the origin of tumor. But of course, bilateral posterior crinoid process sometimes the obstacle to access the lateral margin of the tumor. So in such situation, I widely drill out bilateral posterior crinoid and dorsum sella to get a more wider surgical field. I will show our surgical video. At first, we widely drill out the bone, and this is a pituitary gland. We gently elevate the pituitary gland upward to expose the dorsum sella and posterior crinoid. And then I carefully remove the posterior crinoid. And then we dissect the pituitary gland from the medial wall of cavernous sinus. And then we cut the dramata behind the dorsum sella. Now we already go into the circle of Wills. We can find out the clear border between pituitary stalk and the tumor, and also we can dissect the tumor from the perforator. Endoscope can offer the very clear view like this, so we can perform the careful total resection of the tumor with preservation of pituitary stalk and gland like this. So recently, in our institute, most case of the craniopharyngioma was rejected by the endoscopic endonasal approach. In this case, we can preserve the pituitary stalk and gland, and the tumor was totally rejected out. This is a paper we published, how to drill out the bilateral posterior crinoid process. We published this to JNS. This is another case of the diaphragm cell meningioma, not tuberculum cell meningioma, and not planum meningioma. Attachment of the tumor is diaphragm. In such case, transcranial approach also very difficult, but if we use the endoscopic approach, it's easy to directly access the diaphragm cell. So at first we widely drill out the bony structure, and then we cut the dura and mobilize the pituitary gland to the right side. Then this is a diaphragm. It means at the early stage of the surgery, we can completely detach the tumor. So when we start the dissection of the tumor, we not encounter the bleeding. So we can perform the very careful dissection without any bleeding. So we can find out the dissectable plane from the perforator and also optic nerve and optic chiasma. So tumor was very large, but the tumor was safely resected out with preservation of the all function. But in case of the meningioma surgery, we have to watertightly seal the dural defect. So we insert the fat tissue to subdural layer and put some suture to fix the fat tissue. We make the knot outside the nostril and then slide in the knot to deep area. And finally, seal the dural defect with a septal flap like this. This is a post-op MRI. Tumor was totally resected out with preservation of the memory and pituitary function, and the dural defect completely sealed like this. We also published how to make the knot outside the nostril and then slide into world neurosurgery. This is another case of the lower clivus meningioma. If we operate this tumor by the lateral suboccipital approach, we have some risk to damage the lower cranial nerve. And if we choose the transpetrosal approach, we have some risk to damage the sixth nerve. But attachment of the tumor is a lower clivus. So endoscopic endonasal approach can directly good view to attachment of the tumor. So I drill out the lower clivus and then cut the dura like this. When we start the tumor removal, most part of the tumor was devascularized. So we can resect the tumor very bloodless surgical field. This case, tumor was very fibrous, but we can resect it out the tumor with a QSA piece by piece and decompress the tumor from the brainstem. This is a basilar artery and perforator, and this is a hypoglossal nerve. And this is the tumor ventral side of the VA, like this. This is the tumor ventral side of the lower cranial nerve. And finally, we reach the lateral margin of the tumor. It means the medial side of the duodenal canal. And finally, we reach the tumor ventral side of the 7th and 8th nerve. So we confirm the most part of the tumor was resected out like this. This is a post-operative MRI. Most part of the tumor resected out and preservation of the lower cranial nerve function. We measured which part we can reach by the endoscopic enonasal approach using the voxel-based lesion mapping. Red area indicates that we can reach this part by the endoscopic enonasal approach. And blue area is we reach by the transcranial approach. So this data show that we can reach the central skull base by the endoscopic enonasal approach. This is another case of the chondrosarcoma occupies the cavernous sinus. But origin of the tumor is a bony structure. It means the inferior wall of cavernous sinus. In such situation, endoscopic enonasal transpterygoid approach very useful. This is the base of the pterygoid process. We drill out the base of pterygoid process and reach to the foramen lacerum and drill out the bony structure around the carotid artery. So this is a cella floor and this is a cavernous sinus. We cut the dura, lateral side of the cella floor, and carefully expose the calcified tumor, medial side of the ICA. We carefully dissect the tumor from the ICA. We already drilled out the bony structure around the ICA, so we can gently mobilize the carotid artery for safe resection of the tumor. This is the tumor in the cavernous sinus, but already the all cranial nerve shift to the upward or lateral side, so we can get the safe corridor to remove the tumor. This is the dura mater lateral side of the carotid artery. We cut the dura and remove the tumor lateral side of the ICA. In this part, we have to carefully dissect the tumor from the sixth nerve like this. So all tumor was safely resected out with preservation of the carotid artery. We confirm the blood flow using the ICG. This is a post-op MRI. All tumor was resected out and abducens palsy improved. This is a paper, How to Mobilize the Carotid Artery Through the Endoscopic Enonasal Approach. We published this technique, World Neurosurgery. Then my topic moved to the endoscopic keyhole approach. At once, I will show our endoscopic keyhole subfrontal approach. Usually, we put the incision around eyebrow and put the craniotomy with the size of 3 centimeters. And then we insert the endoscope to paracella area. We can get very wide and clear view around both optic nerve and optic chiasm. So I apply this technique to medium or small size of 12 cell meningioma. At first, our craniotomy is about the 3 centimeter, and then we insert the endoscope to subfrontal area. Endoscope can offer good view around the attachment of the tumor like this. we carefully drill out the superior wall of optic canal. I drill out the canal and also drill out the tuberculum cell. Now optic nerve was decompressed. I cut the duramata of the optic canal for decompression of ipsilateral optic nerve. Endoscope can offer good view to medial side of ipsilateral optic nerve. So we successfully decompress the tumor and remove the tumor step by step. This is the contralateral optic nerve. And finally, all tumor was resected out, like this. This approach also can be applied to the olfactory groove meningioma. Surgical strategy is the same. At first, I put the skin incision along the eyebrow and put the craniotomy about 3 centimeters. And then we insert the endoscope to the frontal base. I detach the tumor very carefully, and then after detach the tumor, we dissect the tumor from the frontal base. At that time already, we not encounter the bleeding, so we can achieve the very careful dissection of the tumor. This case also, we can anatomically preserve the olfactory tract, and all tumor was resected out. Skin incision very small, and tumor was totally resected out. We also published this technique to World Neurosurgery 2023. And then this is a modification of the subfrontal approach. This tumor occupies a lateral wall of cavernous sinus. In such situation, endoscopic transorbital approach very useful. So I perform the small craniotomy and orbitotomy and then insert the endoscope. So surgical corridor is like this. I will show our surgical video. At first, I cut the skin just under the eyebrow and expose the orbital rim like this. And partially expose the frontal bone, very small area. And we remove the orbital rim and frontal bone, very small area, like this. And then we insert the endoscope. This is a orbital, and this is a superior orbital fissure. After expose the superior orbital fissure, I cut the meningo-orbital band and peel off the dura. So surgical procedure is completely same as the transcavernous approach. This case, the tumor was schwannoma. So we expose the tumor like this, and then start the debulking of the tumor. We preserve the normal trigeminal fiber and dissect the tumor very carefully. And finally, all tumor was resected out. Dural defect was covered the duragen, and then fix the fibrin groove like this. This is a post-op MRI. All tumor was nicely resected out through the transorbital route. We also published the surgical technique, endoscopic transorbital approach to the neurosurgical focus. My topic moved to the endoscopic keyhole anterior transpetrosal approach. I put the incision around the temporal base and put the craniotomy with the size of 3.5 centimeter. And then after insert the endoscope through the subtemporal area, we can expose the trigeminal nerve from Meckel cave to brainstem. This surgical view is very similar of the microscopic anterior transpetrosal approach. So this is a small petrous apex meningioma causing the trigeminal neuralgia. So I apply the keyhole anterior transpetrosal approach. I put the craniotomy with a size of 3 centimeters and then expose the GSPN like this. I identify the GSPN using the facial stimulator, and then we cut the dura medial side of the GSPN. So This is a Kawase triangle. I drill out the Kawase triangle under the endoscopic view and then also cut the SPS, most anterior side. Now, most part of the tumor was completely detached. So when we start the tumor removal, we not encounter the bleeding. And after cut the tentorium, we confirm the force nerve. Then we dissect the tumor inferior surface of the tentorium. Then tumor was totally dissected out like this. This case tumor compressor SCA and SCA compressor trigeminal nerve. So I mobilize the SCA of the trigeminal nerve like this. If we insert the endoscope more deep side, we can confirm the sixth nerve and also confirm the 7th and 8th nerve. So this view is very similar of that of microscopic anterior transpetrosal approach. So anterior part of the petrous bone drilled out and the tumor was nicely resected out. This is another case of the trigeminal schwannoma occupies the Meckel cave posterior fossa and infratemporal fossa. But endoscope also can offer good view around Meckel cave posterior fossa and infratemporal fossa. So I apply the same procedure. I put the craniotomy with a size of 3 centimeters and then insert the endoscope like this. We explore the Kawase triangle and then drill out the Kawase triangle. After that, we open the Meckel cave and start the tumor removal like this. Endoscope can offer the good view in the Meckel cave infratemporal fossa and posterior fossa. So all tumor was nicely resected out like this. This is a post-op MRI. Tumor around the Meckel cave posterior fossa and infratemporal fossa was nicely resected out. If the size of tumor was large, but the result is the same like this. This is a petroclival meningioma, but the strategy is the same. I skipped the surgical video, but the tumor also resected out. We published this technique this year to the 2 papers. One is a JNS, include a video clip. And recently also we published the technique to the operative neurosurgery this year. Finally, my topic is an endoscopic keyhole interhemispheric approach. This is a relatively large falcotentorial meningioma. But if we insert the endoscope, we can detach the falx and tentorium at the early stage of the surgery through the keyhole. We place the patient to lateral position. So direction of the superior sagittal sinus is along this direction. We insert the ventricular drainage to the opposite side and then start the small keyhole. I put the keyhole and then insert the endoscope like this. Endoscope can offer the direct view along the falx and tentorium. So we coagulate the falx and tentorium very effectively and continue the debulking of the tumor using the QSA. And then we perform the debulking and finally preserve the deep venous system like this. This is a post-op MRI. Tumor was nicely resected out like this. If the size of tumor is large, but the concept was same, we place the patient to lateral position and then start the keyhole endoscopic approach. We effectively detach the tumor and continue the debulking, and finally all tumor was resected out through the keyhole. This is a post-op MRI. We resect out the tumor nicely and also preserve the venous structure. We also published the keyhole interhemispheric approach. to the world neurosurgery. So today I will present the two surgical techniques, endoscopic endonasal and endoscopic transcranial approach. Those approaches can be very effective procedure for removing the various skull-based tumor. Thank you for attention.
Thank you for the wonderful presentation, sir. Dr. Dwarka, should we take questions now or?
Yeah, I think we can take questions now.
Yeah, I think from the comments box, I think one was on your how means your videos are fantastic with such a small keyhole, and you seem to be using the kind of more than two hands. So how do you get enough space? What are the kind of tricks you employ to get more hands into the field with lots of instruments with such a minimally invasive approach?
Thank you for your question. In my feeling, if we perform the keyhole approach, our assistant not fix the endoscope. We mobilize the endoscope so we can decrease the confliction of the instrument. Endoscope, microscope, our assistant move to avoid the confliction.
Your assistant is holding both the endoscope as well as one instrument, and you have two instruments in your hand.
Yes. So we can use the three instrument and get very magnified view. This is the key
Do you
point.
have any specialized coaxial instruments, like single shaft instruments?
Yes,
Do
yes.
you?
To perform the keyhole approach, I recommend to use a monoshaft instrument.
Okay. And these endoscopes are 0 degree or 30-45. Which one would you like?
In case of the keyhole approach, I prefer use 0 degree endoscope. Occasionally, I use a 30 degree endoscope, but 70 or 45 is too much.
Okay. And another comment was on kind of they wanted to see how the scopes are outside, but I think that we won't have any photos or videos. None of the surgeons have. I think Dr. Sumant had commented, kindly show the exterior view of how you handle instruments. But I think that is difficult.
Next, in the next presentation, I will show the setting of the keyhole approach. Okay, thank you.
Dwarkanath.
Yes, sir.
Yes, sir, Dr. Sampath, sir, please ask.
Excellent demonstration. See, are you interested only in tumors or some other lesions also?
Sorry?
Are you interested on tumors or other lesions also, other than tumors?
The endoscopic keyhole approach?
Yeah.
I think the keyhole approach is useful for tumor surgery because in the skull-based tumor, just detachment of the tumor and continue the internal debulking. We make the space. But the vascular region, we have to observe the surrounding structure. So in such situation, I prefer the classical transcranial microscopic skull-based approach for vascular region. Thank you.
See, you have demonstrated this clival meningioma. It was excellent, and you have demonstrated all cranial nerves along with the pons and also medulla. Is there any chance to do any basilar system aneurysms?
I'm not sure, but in the vascular surgery, the angle of the clip is very important. So I think the microscopic procedure is better than the keyhole. Just my impression.
No, what I mean, the basilar artery, when it is in the midline, you are doing clival resection, that is drilling of clivus. Then it will be on directly, it is be accessible for us to clip the aneurysm. That's why I asked, because your surgery, keyhole surgery for supratentorial also, it was excellent. Thank you very much.
Thank you.
Professor Goto, there was another question as to which endoscopes you use.
He has already answered. Dr. Dwarka, he has already answered.
Okay. So regarding this transorbital approach, how do you select your cases for the transorbital approaches?
Of course, thank you for good question. The selection of surgical approach very difficult in some case because some region surgical approach overlap. For example, if the trigeminal schwannoma occupies a Meckel cave, we can access the more than 3 approach. One is endoscopic and nasal. We can reach the Meckel cave. And also keyhole temporal approach, we can of course reach Meckel cave. And also if we use a transorbital approach, of course we can reach Meckel cave. And also classical transcavernous approach or classical middle fossa approach also nicely preserve reach the Meckel cave. So I'm not I not have the clear answer to selection of the approach.
Thank you. Thank you, Dr. Goto. It's a wonderful lecture. Thank you. Any
Thank
other
you.
questions, Dandapani? So I think there are no further questions. So we'll go to the next speaker. There's a
Okay.
small change in
Thank
order.
you.
Thank you. Thank you, Professor Goto. I would like to invite Professor Stefan Florian from Romania. Professor Florian is the professor of neurosurgery at Cluj-Napoca at Romania. And he also was the chairman of the Cerebrovascular Disease and Therapy Committee at the WFNS 2021 to 2023, and also the Bylaws Committee at the WFNS in 2019 to 2021. He's a very famous neurosurgeon in Romania, and he's also known as the aneurysm maker. So hundreds of aneurysms. But today he's going to speak on a topic. Today he's going to speak on a topic which generally in the what you call the areas of, it's a gray zone for many neurosurgeons as well as oncologists and radiotherapists. So optic pathway gliomas are basically have a lot of management issues, and Professor Florian is going to speak on them. So I welcome Professor Florian and thank you for accepting our invitation to speak in the NSI webinar.
Thank you very much for your invitation. So I already shared my screen, and I'm glad to see two of my former and actual colleagues of the Cerebrovascular Committee, Professor Srinivas and Professor Mura. That's the proof that we are still active and still involved in the education, the main reason for World Federation exists. So yes, it's a gray zone. I wanted to apply for an article on this topic, and it was rejected because the reviewers mentioned that I am too aggressive in these cases. So I don't think that. There are still cases in which we should be involved as a neurosurgeon, and I don't have any conflict of interest. I will show you why I consider that we should act in some selected cases and operate on them. So the history, it's not so long, but Dandy was the one who classified these tumors in two large groups, and he mentioned that these tumors are classified in two groups. One, it's those who are predominantly intraorbital and those who are predominantly intracranial. And regarding the operation itself, Maxwell, more than 65, 70 years ago, described an operation performed by his team on gliomas of the optic nerve pathways in childhood. So the pioneers on this field are more than 70 years old. This was a picture of a case of Dandy from the Dandy archives. So how they are presenting, I will go a little bit fast on the general data. Most of them are asymptomatic, some are symptomatic, and those with intraorbital tumor will present with proptosis, strabismus, and visual loss in the most extreme cases, and intracranial tumors can present with visual alteration or loss. But what is interesting, some of them will present endocrine disturbances, other diencephalic syndrome, and spasmus nutans, which is quite specific to this kind of tumor. And in some cases, there are signs of increased ICP due to the obstructive hydrocephalus. We should evaluate these cases from multiple point of view. The visual acuity should be identified. Nowadays, more and more importance it's given to retinal optical coherence tomography, and we published some articles on this, and we demonstrate that alteration of this investigation is obtained not only in the same side, but also in the contralateral side. And still, the MRI remains the golden standard. We can identify not only the lesion, the extension, the involvement of the chiasm of the optic nerve, and also the consequences of this. And adding the spectroscopy, DTI, we can have more additional information in order to decide whether there is a case of for surgery or not. And based on this, we have nowadays the planned classification with 5 stages, with single optic nerve, bilateral optic nerve. These are located only the optic nerve. The stage 2 with the central chiasm, or asymmetrical, symmetrical. Stage 2 with a symmetric optic tract involvement, and stage 4 with diffuse posterior tracts. And additionally, if there is a neurofibromatosis case, we will have NF1 plus and NF1 minus, and the metastatic status, it's also important. From a pathological point of view, these are tumors that are low-grade gliomas in almost all of the cases. Pilocytic astrocytoma, but nowadays more and more cases are described in a new category, pilomyxoid astrocytomas, that have a more aggressive behavior, a higher recurrence rate, and a CSF dissemination. Regarding the natural history, we should be, when we decide about a certain kind of treatment, we should be informed that up to 50% of the optic pathway gliomas remain stable and do not require any intervention. And rarely a patient with neurofibromatosis 1 rarely progress after the patient is 6 years old. There were cases published with spontaneous regression of the tumor, and as the guidelines of the diagnosis and management of optic pathway gliomas are underlying, it's probably better to have a strategy of managing this patient on an individualized basis. Observation, it's a valid option when we have the small tumors with preserved visual function, incidental findings in patients with NF1, small tumors that are not obstructing the CSF pathways, and patients with radiological stable tumors diagnosed during childhood. And the prolonged follow-up should be considered in patients who suffered visual decline or radiological progression during the childhood, and adult patients with late onset OPG. These are the general recommendation. What kind of treatment? We should treat the patient with increased ICP, with reported visual deterioration, diencephalic syndrome, tumor progression, and as a treatment method, we have chemotherapy, neurosurgery, and radiotherapy. Regarding the chemotherapy, nowadays the treatment for symptomatic and progressive tumor, especially in younger children, and the nowadays regimen, the recommended for the children's below 5 years of age. Alternative regimen are vincristine and cisplatin and temozolomide as the second line. But now with the molecular analysis of these tumors and discovering more and more going deep inside the knowledge of this tumor, more and more drugs appear in order to target the molecular aberrations of this tumor. So the goal is to minimize the toxicity and to maximize the survival and functional outcome. And we know, based on the recent study, that OPGs are characterized by activation of BRAF oncogene, and this is translated into abnormal MARC pathway activation. So we should act accordingly, and we should use molecular therapy targeting MARC pathways, and nowadays selumetinib, it's more and more largely used in NF1 patients. So radiotherapy, it's nowadays not so largely used like it was in the previous year because of the secondary effect. We are speaking about small children, and small child, and the effects on long term are well now categorized, and but still in some cases we can apply the radiotherapy. Surgery, it's not the current recommended standard of care for a primary attempt of this tumor. Early surgery for debulking it's possible with acceptable risk in patients with cystic tumors, large tumors, and exophytic tumors, and those who are mainly in the hypothalamus. So there are two broad categories. We can act with surgery. Surgery for the secondary effects, and these are because of the hydrocephalus, we can perform VP shunt and with an endoscopic fenestration and unilateral VP shunt and or bilateral ventricular catheterization. For the vascular complication of the radiotherapy or the disease itself, we can use in Moya different kind of revascularization, and sometimes we can also decompress the optic canal in order to decompress the optic nerve. But these are rarely encountered in the biopsy. It's not really indicated in typical MRI findings, and I rather prefer to have a direct vision on the lesion when I perform biopsy. So tumor debulking, there are arguments in favor of that, and we can protect the vision on the good side, control hydrocephalus, delaying radiotherapy, exophytic and cystic lesion with visual impairment, increased intracranial pressure, and tumor may naturally regress following surgery. Cons are we cannot attend the surgery when useful on the useful side. Useful vision preserved on the side of the tumor, optic chiasm localization, diffuse gliomas, and there is a high risk of damage on optic pathways and vascular supply of hypothalamus. In my experience of more than 1,900 gliomas operated, I encountered only 21 cases of suspected OPG. Not all of them were confirmed pathologically, and in children 14 children with this kind of pathology. In 2 cases, there was a controversy related to the pathology. This is one of the rarest cases. I operated more than 20 years ago with an unilateral location of the glioma in the optic nerve extended toward the optic canal into the chiasm. And at that time, we believe that if we resect the optic nerve, we prevent the extension toward the chiasm and the contralateral nerve. So nowadays, we should try everything else in order to prevent this kind of operation. In the last 15 years, I use mostly the frontolateral approach in most of the cases for anterior skull-based lesion, and accordingly also for these kind of lesions. Sometimes when the extension of the tumor is into the mesencephalic system, I use a large pterional approach. But in most of the cases, we can reach the lesion with a simple frontolateral approach. Translamina terminalis, it's also a valid option for the extension on intraventricular extension of the tumor, like in this particular case with, again, frontolateral approach. In some cases, it's a case that was operated before in another center, and he came to us with this recurrence with an aggravation of the increased intracranial pressure and also of the vision on the contralateral side. So we decide to operate because these symptoms. The surgery in the recurrence, it's much more difficult because you can see, you cannot identify all the structures, and identifying the optic nerve in this mass and covered by scar, it's quite challenging. But at the end, we succeed to perform a quite, you see here, only a small amount of a tumor remained, but still stable after 6 years after the follow-ups. It's very important to preserve all the large vessels, and also, if it's possible, the perforators, which are covering the tumor, but not always possible. Internal debulking, mobilization, and preserving the arachnoid that covers the structures, are the key for a successful surgery. And sometimes we can have, during the surgery, the final diagnosis. We thought that in this case it was optic pathways glioma, and he was treated for this kind of tumor, but the tumor evolved, progressed, and we decided to operate, and we obtained a complete removal. This was a child that we accepted when he was 1 year and 3 months, many years ago, and we decided to remove even if the patient was refused by many other centers. So there, in this kind of cases, you have nothing to lose. If you don't accept to operate this case, the patient will certainly die because of the increased intracranial pressure, brain herniation. He will became before that blind and completely handicapped. So we decided to operate and to offer at least a chance. And we were lucky because we obtained a almost complete removal. And despite a difficult postoperative course, the patient survived, and he was good, quite good. You will see. I will go a little bit faster. I don't have enough time to present all. And at the end, we obtained complete removal. But after 5 years, he was readmitted with this recurrence, So we again re-enter, we debulk the tumor, the cystic part, and we try to preserve as much of the structure we recognize during the surgery. We identify the contralateral optic nerve, and we certainly preserve the large vessels and obtain a quite satisfactory resection. So we also can have a surgery for this kind. This is a patient 2 months old with no other chance than surgery in order to survive. And we obtain a complete removal, and the patient is in a good neurological. And this case, we told it also that it's a optic pathway. In fact, it was a craniopharyngioma, the same 2 months old age, and we should offer these small children a chance in order to obtain. And once we have obtained a survival, this is the first step in order to obtain recovery. So in conclusion, more difficult to decide when to operate than to operate. Long-term natural history, reduced impairment of vision, and discrete neurological signs. Surgical debulking is effective in controlling tumor growth without significant postoperative morbidity. For high-risk patient, combination of surgical debulking with chemotherapy is the nowadays therapeutic recommendation. The take-home message is a child is not a small adult, but it will become one. Sometimes the decision belongs to you. Do your best and help them to become adults. Thank you for your attention.
Thank you, Stefan, for that wonderful talk. I had a question. I had this question, like, how do you manage children under 5 years and children above 5 years? Do you, I mean, how do you, or what is your line of management? Chemotherapy, radiation? How do you select which to use?
We are working in a group of neuro-oncologists and neurosurgeons. I'm not eager to operate a child with a stable lesion, which is in a good neurological condition. I discuss, but if there is a progress despite the chemotherapy, and if the child is below 5 years of age, nowadays 5 years it's the threshold for radiotherapy in this region, and there is a mass which is compressing. I'm not afraid to offer surgery, because I know what I have to do, and I now have enough experience to know when to stop. So I have I have some cases in which I perform large reduction, not a complete reduction of the tumor, and the rest of the tumor is stable for many, many years without any additional treatment. So don't be afraid to operate these cases, but don't be too aggressive.
So what is your line of management for cystic tumors? I mean, if there's basically only a cystic recurrences, do you...
So if it's a cystic tumor, you saw that in 2 of the cases I presented, once you open the cyst, you can manage and you can identify the important anatomical structure surrounding the lesion. So if there is a cyst, you reduce the cyst, and then you go to the mass, tumor mass, in order to reduce, but preserving the optic nerve when it's visible, but sometimes it's not really visible on one side or on the contralateral side. But you can go to the optic canal and you see how the filaments of the optic nerve are spread toward the capsule, and you preserve a layer of the tissue around that. it's not important to remove completely. It's important to reduce the cyst and the mass, which is closer. And the tumor will remain stable for many years. And some cases will never grow again.
One of the main fears or what surgeons think is the hypothalamic involvement of optochiasmatic gliomas. So, what has been the incidence of hypothalamic damage, and what are your tricks to avoid hypothalamic damage?
It's like in craniopharyngiomas. You also have the craniopharyngiomas which are involving the hypothalamus. And I do not force and I do not recommend to force the dissection into the hypothalamus. Sometimes, in some cases, the cystic part is toward the third ventricle, and you can remove easily the capsule that it's detached from the hypothalamus. This is the ideal case. But when you see that there is adherence to the hypothalamus, it's better to leave that.
Dwarkanath, one question.
Sir, yes.
What is the outcome of vision following surgery?
So in most of the cases, the outcome it's good. At least the patients are coming with the visual alteration, at least sometimes loss of vision on one side. So we cannot expect the vision to be recovered on the side in which is deeply affected or lost. But on the contralateral side, in most of the cases, we preserve the vision, and even the vision is improved because we decompress. Usually these tumors are not involving both optic nerves. So there are most of the cases, at least in my experience, asymmetrical. So you can preserve on one side, and these are small children which adapt very nicely with this visual loss. It's not like in an adult. You grow up with the bilateral vision, and once you lost, you are handicapped. They grow up with these deficits, and they can adapt, and they don't feel this disadvantage.
Do they present like a diencephalic syndrome?
Diencephalic syndrome?
Yes.
Yes, and immediately after the operation in these large tumors, they present, and the case 5 years old that I presented, he spent in our hospital more than 2 months in the intensive care. But we should manage this, and in time, as I mentioned, child is not a small adult. They recover much easier and much faster than the adults. So I'm not so afraid of diencephalic or long-term diencephalic syndrome if I know that I did not destroy the diencephalon. If you preserve the diencephalon, the child will recover.
Fine. Thank you.
Thank you, Stefan. Wonderful talk again, as usual. So I think there are no further questions, so we can go to Professor Mura. A very good morning to Dr. Mura. It's early in Mexico, so thank you.
Thank you.
Yeah. So
I have to go back in my webinar.
Yeah, we understand.
I will transfer your salute to Lanzino and okay.
Yeah, he's next on the invitation list.
And yes, all the best. All the best.
Bye.
So,
Bye, Stefan.
my pleasure to welcome Professor Jorge Mura from the University of Chile. He's a professor of neurosurgery, and he's one of the first professors since 1987 in Chile. He did his cerebrovascular and skull-based fellowship in Brazil with Professor Evandro de Oliveira, and he started the fellowship program in cerebrovascular surgery at University of Chile in 2002. He was elected the vice president of the Chilean Association of Society of Neurosurgery till 2021, and now is the president of the Chilean Society of Neurosurgery, or the immediate past president. His fields of interest are primarily cerebrovascular and skull-based surgery, and he's going to speak on a minimally invasive MIPLATA approach for neurosurgical lesions around the cavernous sinus. It's a very interesting approach, and I would invite Professor Mura to speak on this. Thank you, Professor Mura.
Thank you very much for your kind presentation. I want to ask you. You see my screen? Yes.
Yes, we see your screen. You just have to, yeah, perfect.
Excellent. For me, it's a great honor to talk to you today about this concept about the mini pretemporal approach. I will show you that if you made a PubMed search, the mini pretemporal name is still no published, but fortunately we have a video accept that was made for a former fellow, Rafa Martinez, who we introduce finally the name in the literature. Is very important. And for me, it's a great honor to be here with you today. And I always remember Professor Evandro. I made a fellowship with him in 2020, and I very grateful always with the Elder Tedeschi and Wen Hong Su. They teach me the microsurgery and neuroanatomy, the most important concepts that we use in our surgeries. And Elder gave me this picture in that time in 1998. And you can see there that if you see the cavernous sinus for the lateral side, similar that the Professor Goto showed in his lecture today, we have a very good space to go to the posterior fossa through the cavernous sinus, and you don't have any bone. Between the Kawase triangle, Pitus apex, and the posterior clinoid, you have a very good space that the inferior limit is the sixth nerve, and you don't have bone. The thing that you have is the tentorium. And if you can remove the tentorium, you have a very good space to get the posterior fossa. This is very good for vascular lesions, for tumoral lesions, independent of the size of the lesion. Professor Goto showed us that the endoscopy is a very good tool that we can say that we can use today in different lesions, and I think that in the future we will be able to do full transcavernous approach to the transorbital endoscopic approach. We are working in that subject, and I think we will publish very soon the concepts about the surgery that the brilliant showed Professor Goto about this. We published our approach in 2021 based in the sphenopetroclival meningiomas. The sphenopetroclival meningiomas for the residents are that meningiomas that are a combination of the cavernous sinus meningioma, a petroclival meningioma, and a sellar meningioma. These kind of lesions involve everything in the region and are very demanding lesions in order to get a very good result with good functional results. We need to preserve the nerves in the cavernous sinus. This concept of MIPLATA is based in a small craniotomy, in a mini pretemporal craniotomy, based in a mini pterional craniotomy, and using the extradural corridor. The extradural corridor is not used the roof of the cavernous sinus, is used the lateral side of the cavernous sinus. This is based mainly in the philosophy of Japanese neurosurgery, and is used the anterior portion of the approach. That's why you don't need orbitozygomatic, you don't need transzygomatic approach, and we can show today that using even the orbit as a root, you can get the proper view of a different kind of lesion like trigeminal schwannomas, chondrosarcomas, etc. If you carry on PubMed, as I told you about mini pretemporal, there's no results. If you look after mini pterional, it's 99 results. But this video about mini pretemporal approach was published online in Operative Neurosurgery in November 18. only a few days ago, 12 days ago. And this will be published in any moment in the PubMed, in the literature. It's very important because we are talking today about something new, a new concept. And the concept is a concept that came from the history, came first from the management of paraclinical aneurysms and clinoidal meningiomas. And after that, we combined with endoscopy and now with the MIPLATA or minimal invasive posterolateral transcavernous transtentorial transpetrosal approach. We published the concept of the surgery in 2023 in the master collection of the operative neurosurgery. And we show this with videos. This work was developed for Arnaud Benet, a neurosurgeon that finished this residency in the Barrow Neurological Institute with Professor Lawton. And this is the code that you can see the videos for free in internet. And this is the different levels of the same surgery. We start with the mini-pterional extradural approach. We follow with the mini-pretemporal extradural approach, and finally we can combine with endoscopy, and we treat no meningeal lesions like tumors in the incisura or tumors invading the posterior fossa or vascular lesions in the posterior fossa. Everything is based in the work of a very important neurosurgeon that I think the history is not fair with him, is Akira Hakuba. He made everything. He published this paper in 1982 about the management of this kind of philosophy. I was very lucky because I knew him in 1998. He came to Sao Paulo and I was there with Dr. Evandro in my fellowship, and he gave me his book. He signed his book. And in this book, in the paper, we can see all the concepts: the dissection of the lateral wall of the cavernous sinus, the opening of the Parkinson triangle. We use today the opening of the Parkinson triangle for vascular lesions. We now making the proximal control in paraclinical aneurysms in the Parkinson triangle. We are not open the neck anymore, and we are not using the clinoid segment anymore because it's narrow, and the Parkinson triangle is much better. And of course, the extradural anterior craniodectomy, he was the first one who described this. And he described the drilling of the Kawase triangle before Kawase, at least 2 or 3 years before. And then Hakuba described, of course, the orbitozygomatic approach, and then he described all the things that we use today. If you see the dissection of the book of Professor Hakuba of 1996, and you see the MIPLATA dissection that we made this year to show the surgery, is the same. It's the same. The only difference is the craniotomy. We use a minimal invasive craniotomy, a mini pretemporal approach, but the concept is exactly the same. If you see it's difficult to differentiate the dissection that Professor Hakuba showed in his book for the dissections that we are doing today. And for me, of course, that Professor Goto is listening today and listening to him because he's the chief now in the service of Professor Hakuba. Of course, I knew the Oata Sensei as well, and we shared this. And I think the history must be fair with the people who really describe the surgeries. The MIPLAT is based on this. This is the neuroanatomy. This is a mini-pterional approach. And you can see if you use the extradural corridor, you open the cavernous sinus, you split the tentorium, you identify the fourth, the third, and the Meckel's-Cave entry of the fifth nerve, and you start to take out the dura mater. You can identify all the nerves, and then you can go to the posterior fossa through the cavernous sinus without any trouble. It's very safe surgery, and you can see all the anatomy. If you are concerned with the sixth nerve, there's no problem because the sixth nerve is under the Gruber ligaments. It's not over. And then if you see the Gruber ligament into the cavernous sinus, you can protect the sixth nerve. And you can take all the things in order to see now. We have now 107 of these surgeries. This is a photograph of a craniopharyngioma, and you can see in this left side, the carotid artery, the anterior cerebral artery, the MCA. We split the Sylvian fissure. We protect the brain with the dura mater. You can see the skeletonization of the third nerve, the fourth nerve, and the fifth nerve. We take out the tentorium completely, and we drill, of course, the anterior and posterior clinoid in order to get access to the posterior fossa. You can see the basilar in the bottom, and you can see the opening of the lamina terminalis because this was a craniopharyngioma surgery. If you put endoscopy like Professor Goto showed today, we can see everything in the posterior fossa. We use endoscopy. It's a little different from transnasal and it's similar to the transorbital, but our problem here are the nerves, and then we need a more fixed equipment to use the endoscopy. We use the Mitaka arm, the uni arm, that is very good, pneumatic one, to secure the endoscopy, and we can use in the posterior fossa very safely. I think maybe a robotic arm will be better. And the other thing is the instrumentation, the suction irrigation that we use from the endoscopy. Of course, these are Japanese designs, and the Kamiyama scissor that is very good because the shape of the scissor allowed you to dissect properly the nerves in the lateral wall of the cavernous sinus, because you follow the nerves from the cavernous sinus to the cister, or to the cister to the cavernous sinus without hitting the nerves. The straight scissors hitting the nerves, I can show you in a video. And the base of all of this is neuroanatomy. The mini-pterional approach is a center approach. Half frontal, half temporal. In the middle is the lesser wing of the sphenoidal bone, and in the bottom is the anterior clinoid process. And then if you dissect properly and you use the infratemporal approach, you can have the mini-temporal concept that is 2/3 temporal and 1/3 frontal. This picture is with Professor Natal and Professor Figueiredo, who described the mini-pterional approach in two different papers, very close one to another. I take this from a presentation recently that I went to Mexico. I'm in Mexico again, but in another city. And Professor Radovanovich talked about the development of the evolution of the of the minimal invasive surgery. One is the root, okay? One is the root, the microcraniotomies, supraciliary, transorbital, or endoscopic portal craniotomy, okay? And the other direction is the re-expansion of the skull base. That is our concept, is opening more the cavernous sinus, use more the cavernous sinus in order to get the posterior fossa. And he showed very interesting paper, very similar to the work of Professor Goto, that they do a biportal endoscopic fully approach for clipping of the MCA aneurysms. We don't have time for this, but it's very nice surgery. The view is very good, and if you had a proper exposure of the vessels in proximal distal control, you can treat, of course, vascular pathology. And I was very proud because he cited our paper as the base of the concept of re-expansion of the skull base. Our paper, original paper about the extradural mini-pterional approach. And then I show you that from 1999 to 2014, you do the classic surgery, but we changed in 2015, 10 years ago, and we start to use the micro Hakuba. We named the micro Hakuba the true keyhole approach, that is endoscopic based approach for when the lesions are small. The concept that Professor Goto showed today, that's basically. And the mini Hakuba, who is a microsurgical version that is based in the mini pretemporal approach. And this is a concept that we name key exposure because it's not keyhole, it's not classic, it's different. It's based in the exposure in the bottom of the surgery. And we publish all of this, of course, in vascular pathology, in sphenopetroclavian meningiomas. We develop special rongers in order to use no-drill craniodectomy to decompress the optic nerve, because the heating of the optic nerve maybe is the cause of the compromise of this nerve. But these concepts are not for our concepts, are concepts published before. This is a paper for William Caldwell, 2006, and he described the philosophy. And the good thing about this paper is the first one who put the name of Professor Hakuba at the level of Dolens and Kawase in the description of the management of the cavernous sinus. And this is very important because as I show you in the history, sometimes the people who are the most important are forgotten, and for me it's very important to try to be fair. And we published this about the other thing is the mini pretemporal approach. Mini pterional pretemporal now, the proper term is mini pretemporal because it's different in anatomy. For sphenopetroclamic meningiomas, you can see here huge lesions with the compromise in the posterior fossa, in the middle fossa, in the cavernous sinus, and the sellar region. And if you are based in a mini pterional, but you use expansion of the skull base, you can use the tumor in order to give you the space. The same concept that Professor Goto showed in the falcotentorial meningiomas. You use the meningioma to give you the space. You don't need to base your surgery in the craniotomy because it's not needed. I told you because I did this for 15 years and we change because we can use the tumor. We can free the nerves. The morbidity going for the middle fossa is not too high. The only concern you must have is with the veins. You need to preserve the network of the veins in the temporal tip in order to avoid any venous compromise. And you can see if you take out the tentorium, even if it's calcified, you can take completely. And then you can free the fifth nerve. We are freeing here the fifth nerve and taking the posterior fossa tumor, like Professor Goto showed in the keyhole transendoscopic approach. But you see here was most extensive tumor. That's why we use the microsurgical route. And you can take all the middle fossa tumor, most of the posterior fossa tumor. Our limit is the internal auditory meatus because we need to preserve the facial nerve. And what we do a two-stage surgery. But the second stage is very simple because it's just a retrosigmoid approach. This is the temporal lobe, this is the cerebellum, the facial nerve, the sixth nerve in the bottom, the lower cranial nerves, and you can see that you can free everything. And the most important thing is you have a nice MRI, but the most important, you have a nice patient. Only a mild facial palsy, no compromise of any neurological function in a terrible tumor, because we combine different concepts about minimal invasion in order to get good results as well. I did this tumor using a combined transpetrosal approach before, always described for Hakuba first, the pre-sigmoid approach, combined with the middle fossa, but now I use two-stage, going first for the middle fossa, and after that, just retrosigmoid approach is less invasive, and you have the same results. These are levels of the same surgery. I just want to show you this short video because it's very important to understand that this is a mini pterional craniotomy. We open the back of the surgery, the most distal portion of the Sylvian fissure. This is made for my fellow. It's not me. And why we do this? Because we don't put a lumbar drain anymore. If the patient have not ventricular big ventricles, it's hard to put a ventricular drainage. And then we use just the natural drainage of the CSF. You can see the relax in the dura mater with no retractions. And then we follow the principles of Dr. Hakuba, the peeling. We use our special developed rangers. We take out the anterior clinoid. We have more than 1,000 anterior cranioidectomies extradural with no lesion of the carotid. I never seen a lesion in the carotid artery. It's a very, very high concern of the people who do subdural cranioidectomy. But the key of the surgery is the peeling of the middle fossa. And we use the tumor. We made the peeling, we take out the exophytic tumor, we expose the lateral wall of the cavernous sinus, and after that, we expose the GSPN, the Kawase triangle. For me, it's Hakuba triangle, but the people call Kawase triangle. It's okay. And after that, you can free the optic nerve. You see the tumor surrounded the third nerve, and then you have all this portion of exophytic tumor. But what's the important thing about the exophytic tumor? When you take out the exophytic tumor, you have the space. You don't need to retract anymore. You can see no retraction. Only dynamic retraction with the instruments. We can find the third nerve, cisternal portion. We have the third nerve in the cavernous sinus, and then the only thing you need to do is unite both sides. You can use, in this case, I use a hook and a knife, or you can come from the cavernous sinus using the Kamiyama scissor in order to have the same decompression of the third nerve. After that, you complete the resection of the tentorium. You open this, and After that, you can free the fourth nerve. If you find the fourth nerve in the cistern, you can do the same. You can free the fourth nerve from the cistern to the cavernous sinus. You cannot find it. You can do the opposite, coming from the cavernous sinus and follow the fourth nerve until you can find it in the cistern. Okay. Then the third important step in the surgery is the release of the fifth nerve, the same that the professor got to show. You need to free the fifth nerve because the patient have a trigeminal neuralgia, and then this huge amount of tumor you can take because you take out completely the tentorium, you free the fifth nerve, you take the posterior fossa tumor, and you will see in a moment that the fifth nerve will be completely freed from the compression. And sometimes I drill the anterior petrosal bone. Sometimes I leave it depending on the extension in the tumor. In this case, it was not necessary to drill nothing. And that's why I show you this. You have complete freed of the trigeminal nerve, fourth, third, carotid artery, basilar, optic nerve. This is a mini pretemporal approach or mini pterional approach. You don't need to take more bone in the outside. And the reconstruction is with the facial, the temporal fascia that we use, pediculated, like very similar that we use when we treat moyamoya disease. And then it's very important the results. When to finish because my time is over. Because if you do a minimally invasive surgery, it's because you can achieve the same result as the classic surgery. That's very important and must be published. And then we publish this, and our results are as good as the classic, but using a miplata-based surgery. And then the pretemporal approach was described by Professor Evandro in 1995, my mentor. And then I'm going to cut the sound, but only show you that the transcavernous route, they publish again. And of course, their surgery very similar doing for another surgeon. This is a paper from Professor Su from Taiwan. That is the same philosophy, the same decompression of the nerves, but they are based in a fronto-orbitozygomatic approach. And I think that that is not needed. The transcavernous route can do for the minimally invasive and even can be done for transorbital endoscopic approach. And then I think the things are changing because the cavernous sinus is not more no man's land. It's a land that the people can use. And when this paper show about the transcavernous route and the different series, is 226 the biggest series that they show, and now we have almost 300 cases. I think now we have 297 cases about this kind of approach, minimally invasive for this kind of lesions. And the other thing that Professor Gott already showed is the combination with endoscopy. You can use endoscopy combined with this kind of approach. And another thing is when you want to get to the posterior fossa, this is a giant endovascular treat, flow diversion and coils aneurysm. This is the VV junction. You can see the VV junction from the middle fossa. No problem for that. It's difficult to believe, but it's possible because you can drill everything. The only limit below is the entry of the sixth nerve in the medial side, and the lateral side. You need to be careful, of course, with the anterior auditory meatus, and if you go even below to the jugular foramen. If you put the endoscopy, you see this is the endoscope with the uniarm from Mitaka. You can get the posterior fossa. Just to show you here that we can achieve the combination of microsurgery with endoscopy. It's very important to understand that the endoscopy can work together with the microsurgery. You don't need to compete. I don't compete. I use the both techniques in the same patients. And you can get very good results. This is a work of one of my last fellows about in giant epidermoid cysts. We can achieve more than 90% in giant lesions because we use endoscopy. And then, for example, is the view of the miplata approach for the left side. This is the exposure. This is the medulla oblongata. This is the pons, sixth nerve contralateral side, third nerve ipsilateral, fourth nerve transposition joined to the fifth nerve, and this is the medulla of the patient, the sixth nerve of the ipsilateral side. You can see all the basilar. You can see the BV junction with endoscopy, and you can take all the tumor for the posterior fossa using the combination of endoscopy. I'm going to finish. This is a very important work for me. This is a work that my friend Rivas is editing about the the World Federation about the vascular lesions, and we put this chapter only to show that the miplata is good even for giant aneurysms. This is a giant carotid aneurysm, and you can do a bypass. This patient have a STMCA bypass and an exclusion of the aneurysm using minimal invasive approach, just to show you that it's possible to do a STMCA without any trouble using miniterional, and you can exclude completely the aneurysm, got good results. And of course, we show the case that I showed you prior to you. This is a fail of endovascular treatment, and we can clip it. We can get the BV junction from the middle fossa. No problem. We decompress the brainstem of this patient. And then the concepts, just to finish, look at this. We are putting clips in the posterior fossa, in the BV junction. This is the basilar, complete extension of the basilar artery through the middle fossa, and get good results. This is our references, of course, the reference that I told you for Rafa, for our group, and Arnau Bennett, that we developed this concept about the mini pretemporal approach. Thank you to my fellows for all this helps always to show all these different surgeries, and thank you for your attention.
Thank you, Goj. That was wonderful, wonderful talk on the miplata approaches. So the one question I had to ask you was, how did you think of this approach? I mean, how did you develop this approach?
How? I copy to the good ones. I copy mainly my surgery. I think was developed through 25 years. When I go back from Brazil, I told you I did the classic surgery, but my surgery was based in the Hakuba philosophy, the pure extradural dissection. Okay, it's a pure extradural dissection. I start with vascular pathology, paraclinial aneurysms. I have now 474 paraclinial, and then I have a huge experience in that, and I use that experience. Okay, but when I treat the meningiomas, not the petroclival, they combine the sphenopetroclival. For me, it was a nightmare because I used to do the combined approach, the pre-sigmoid combined with middle fossa, huge surgery. The patient did not tolerate well the surgery because you manipulate the posterior fossa, and the posterior fossa is, you have compression of the brainstem. The patient take several days to awake, and I start to think, why how cannot do in a stage surgery? Why? If I can decompress the brainstem for the middle fossa, the only nerves I will manipulate will be the oculomotor nerves, not the facial, not the lower cranial nerves, not the bad nerves. You know what I mean? And then the patient tolerate better. And I realized that was true. I take almost all the tumor. The patients awake very nice, only third palsy that recover very fast in 1 month. And after that, I can go for the next step in the surgery with a very huge space in the posterior fossa. I just put a retrosigmoid approach, and because the tumor is not there anymore, the posterior fossa was very, very comfortable to operate. And then it's easy to expose everything. Like you convert a terrible tumor in a small tumor, you know, in a retrosigmoid tumor. I don't even use the presigmoid approach because it's not needed. Of course, now that I have more experience, I drill more bone. And then now, for example, I drill the internal auditory canal because I want to take all the tumor inside the canal. But the first cases, as you saw in the video, I leave that because I want good results. But for me, the most important thing is I have a very good MRI because I take almost 100% of the tumor. But most important, I have a very good patient. The patient it tolerate very well the surgery. Now I have 70 patients of this kind of tumors. 70 is sphenopetroclival. Petroclival, I have I think 50 more. But the phenopetrocribal, that was the challenge that I based my surgery, is the most important thing, because we found this solution. And to finish the idea, the other good thing about Mi Plata is this: I don't do the approach first, complete, and after I go for the tumor. No, I do a tailored approach. For example, you saw I start the surgery, I take out the anterior clinoid, I free the third and fourth, I go for the tentorium. If I need, I take the posterior clinoid. If I need, I take out the Kawase triangle. If I need, I take the petrous apex. But I don't do everything in the patient in the beginning, because you consume time, you have morbidity, and sometimes the patient don't need it. The same thing happened with the orbitozygomatic approach. I did for every case orbitozygomatic in the pretemporal when I start. But I realized after that I don't use the of the surgery, and I stop to do the orbitozygomatic. And then I think, okay, I do terional, but it's too big. I've never used the frontal side of the surgery because it's based in the cavernous sinus. And then I stopped to use terional, and we start to use mini terional. And after that, I think, okay, I want to go farther. I'm going to use pretemporal. But why I'm going to use the classic pretemporal orbitozygomatic? No, we need to modify. If you use mini terional, I'm going to use mini pretemporal, because I don't need more. And I can show you that is possible. You can have very good. I always say, don't believe me. I can be a liar. I can be a good liar, but
Your
believe to
results are
your
very
eyes, because you can see the videos, you can see the MRIs, you can see the patients. You see, and then I'm very happy because what Goto Sensei showed today before me is the thing that come after. Use endoscopy, use the transorbital approach, a full cavernous transorbital approach. I think is possible, because there are many neurosurgeons who said that is not possible. But many neurosurgeons, to me, that is not possible a transcavernous approach without orbitozygomatic approach, but it's possible. You see?
Yeah. How frequently do you use the endoscope as an add-on procedure? As an add-on.
I use endoscopy in all the non-meningeal tumors.
Okay.
In vascular pathology. You know why? Because in the meningeal tumors, you have nothing to do with endoscopy, because the problem is the tumor itself. If you cannot see the tumor, you cannot see fully the tumor with the microsurgery, unless the tumor is very soft. I stop the surgery, I close the patient, and I go for the retrosigmoid approach after. Because the thing I don't want to do is pull too much the nerves, especially the facial, because the facial is related to the cochlear nerve, and you can leave the patient with death because of the pushing, and then that's much better to go from behind.
Sir, any questions, sir? So thank you, Dr. Mura, for the wonderful presentation. I wish you, I hope to see you soon in AANS and at Boston. So,
Yes, of course.
yeah, thank you. Thanks a lot. And so we'll go to the next topic. There's a video presentation by Professor Sampath. Dr. Sampath sir was one of our teachers, and he's a pioneer in extended endoscopic approaches. And he started the extended transclival approaches to the basilar junction, vertebrobasilar aneurysms. So sir will do a short video presentation on his experience on these extended endoscopic transclival approaches. Sir.
Thank you, Darknath. Today I will be presenting my vascular experience using endoscope and also tumor resection using endoscope. We don't know how far we have come. We have significantly improved from macro surgery, micro, then endovascular, robotic surgery, then radiosurgery, all these things we have advanced. I don't know in future where we are going to. So I will be showing my slide. At present, I am working at Sridevi Institute of Medical Sciences and Research Hospital at Tumkur as a professor. Now my talk is what is the role of extended endonasal endoscopic surgery in skull-based lesions. Especially I will be talking to you today is aneurysms and also fifth nerve schwannomas. So I call this endonasal endoscopic skull-based surgery may be a minimally invasive surgery, but what I will be showing you is like a burrow surgery. So where we do burrow surgery for supratentorial areas, the same way we will be doing inside the nasal cavity. So here the lesions is majority of the lesions will be anterior to brain. So we will not be seeing any brain. When we are not seeing the brain, there is no question of retraction. So what are the favorable to surgeon when we are doing nasal surgery? That is, if the bone of the nasal cavity is totally pneumatized. Pneumatized means when the bone is very thin, our drilling part will be very minimal. So that sometimes we may not be see any bone also. It will be very transparent. We can see the pulsation of the dura that I will be showing to you. So if the lesion is right-sided lesion, visibility will be good. Even though this panoramic view is from the endoscope, it is an excellent view, but right side means that operability, handling the tumor tissue will be easy. And the main problem of this when we are going for a posterior fossa, carotid artery is lying on either side and basilar artery at the top. It is like a triangle, like a three lions standing on these 3 points. So basilar artery will be in the center. If it is deviated, then it will be very difficult to identify the branches of basilar artery. Sometimes we may be mistaken for it. I will be showing in a few seconds. So if there is any, sometimes a dura, there will be a sinus will be there. It is less than 6%. It will be a little difficult to control during surgery. Otherwise, sometimes it will be totally thrombosed. So entering into posterior fossa is not a difficult one. So this is totally a cosmetic surgery. Incision will be seen outside and the cost of surgery will be very low. So this is the incidence. Posterior fossa aneurysms will be around 15%, including all the branches of vertebrobasilar trunk. So this is what I am telling you. This carotid artery will be lying on either side. These are the 3 types. So when the carotid artery, when it is dissected in a diseased body, so one is trapezoid type. The top one is trapezoid, the rectangular, and third one is hourglass. Rectangular is excellent for our surgery because it will be carotid artery will be away from our surgical opening. So there are the different, when we do angiogram, we have to study carefully whether the body, what the aneurysm, whether it is anteriorly facing or posteriorly or vertically. So because why I am showing this figure, when we are putting what type of clip we have to use. So what I face so many problems when I have done these surgeries. So after seeing those surgeries, my conclusion is these are the types of clips to be used for this basilar top aneurysm. So this is the clips, astergal clips, very old one. It may be about 40 years old. So these are the clips I used for clipping the aneurysms. So next I will be showing you the see, next I will be showing you one basilar artery trunk aneurysm. See, the aneurysm is so big. these are the types of aneurysm in so how I have done, this is endonasally. See, that is the what we are seeing is the clivus spot, and you are seeing the cella also. Below the cella, I have drilled out, and now I am opening the dura. So on either side, you can see the carotid artery. This is the carotid artery. This side is carotid artery. The cruciate incision, I have made it on the dura. So you can see the basilar artery there. So I was telling you, if the basilar artery, if is trunk identification is easy. Now what you are seeing is the neck of the aneurysm here. Neck of the aneurysm at the body. This is the continuation. There the bifurcation is there. So if it is straight, so my approach would have been still easy. See the vertebral artery both side which is coming. So now I am using temporary clip that is being applied on the vertebral artery. So this is the neck of the aneurysm. Nobody can identify because it is difficult to identify also. They are all perforators are in the posterior aspect. See the so quite big neck. Yes. Now I have applied and the temporary clip being removed. So after that, in layers, facial atom with the muscle graft I have placed on that. So nicely, which is pulsating. So this is the mucosa which I reflected. So this can be used as a Hadad plaf, or we can use only a, or we can bring it back itself. So this is the post-op angiogram of the same patient. So all the vessels which are seen. See how the patient is walking.
Good. Bidi, bidi. Very good. Fold.
ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿ
ಇದನ್ನು
ಇವಾಗ
ಮಾಡಿ. ಇದನ್ನು ಮಾಡಿ.
ಬೇಡ ಬೇಡ ಫಸ್ಟ್ ಮಾಡಪ್ಪ ನೀನು ಎಲ್ಲಿದ್ದೆ ಅದು ಎಲ್ಲೂ ಇತ್ತ ಫೋಲ್ಡರು
ಇಲ್ಲೇ ಇದೆಯಲ್ರಿ
ಇರು ಇರು
ಸಾರಿ ದ್ವಾರಕನಾಥ್ little difficulty I am facing it.
It's okay, sir.
ಒಂದ್ ಸೆಕೆಂಡ್ ಫೋಲ್ಡರ್ ಇಲ್ಲ ಅನ್ಮ್ಯೂಟ್
Now you are seeing the P1 aneurysm which is quite big. This is being operated. This is P1 segment. Dwarknath, are you listening?
Yes, sir. Yes, sir. We can hear it. See
See
clearly,
the
sir.
sphenoid bone, how I separated from the mucosa. It is a very good demonstration. This is the rostrum. Now after taking out, I am drilling the clivus. So it is like a tunnel. So now what you are seeing is the carotid artery on one side. Next, so I am exposing the carotid artery. It may not be, see Lilly Quitt's membrane, which is seen so nicely and so thick. This is a non-ruptured aneurysm. This patient presented with progressive weakness of one side of the limb. See all the blood vessels. This is the aneurysm P1 part. This is the bifurcation of the basilar artery. See the pons. See, that is the thickened part of the Lilly Quitt's membrane. This is the P1, which is going like that. This is the communicating artery. See, now I am temporary clip being applied. Again, then now temporary clip. It is very tense sac. So to avoid, so I am applying one more permanent clip over it. Yes. Now the temporary clip is being taken out. So following clip, this is the picture. See the mammary gland, which is seen in there itself. It is in the interpreting class fossa. So after that, again, muscle with the fascia, and this is, and flow cell, which is supplied over that. See, following surgery, see the aneurysm is completely obliterated and all the blood vessels which are seen.
Next.
This is the another. This is the another patient having a lipoma. She presented with ataxia and diplopia. So she is around 22, 23 years old. She is a bank manager. She wanted cosmetic surgery only. That's why we planned for endoscopic surgery. So this is the tumor. You can see the tumor here, the white thing. See the extension up to the foramen magnum, it is extended. See the basilar artery, which is in the center of the tumor. So this is best way is to do midline approach rather than from laterally. If you go laterally, definitely we would have injured the cranial nerves. See again the same procedure, the dura being opened. See the tumor being decompressed. Luckily, see the medulla, see the pyramid of the medulla which is seen. And this is all only a connective tissues. See, following surgery, there is a residual lesion which is seen at the lower part and also partly on the one side. So again, this patient re-explored next day. See the basilar artery, how nicely which is seen, ICA is seen, medulla. And this is all around 1.5 centimeters opening at the clivus.
Stop.
This is quite easily suckable tumor. See from the lateral aspect, initially it was not visualized, so I little extended the opening. So with the curved section, I could remove almost all tumor. See, so the nice vision of this tumor. Now I closed with this facial ata with the muzzle. See, this is the post-op. There is no tumor seen. See, completely which is taken out from here. See, this was the entry. See, on both sides which is removed. This is also. Following this, our patient is, she has improved in her symptoms. So if anybody looks at her, there is no surgery is done for her like that. I'll show you this one more. This lady came with a facial pain. So we made diagnosis of schwannoma. This is the picture of this. This is mixed density lesion, which is coming to the midline, even slightly, which is crushed. So we decided to do endoscopic surgery. Dwarkanath, are you seeing?
Yes, sir.
So same procedure, clay was completely drilled. So it was so thin, just little drilling which opens. So the fluid which came out, see the opening of the bone, how much small it is. So bleeding is not the problem. So that can be controlled. See the carotid vessels, how it is on either side it is. So in between I am operating, it is around 1.5 centimeters. So the tumor, which is collapsed part of the tumor, which is seen there. And basilar artery also, the part of the basilar artery is there. See, this is the one which is shifted. See, laterally which is shifted and separated also. So how nicely which is coming out of the blood vessel, basilar artery. This is all CSF which is coming out. So that is the pons what we are seeing it. This is the cella floor. So next to that itself I have drilled. So I am getting hemostasis. This is the surgical I am placing it. I would have shown still more videos by Dr. Goto. He has shown excellent videos, that too especially endoscopic and also key surgery. I was astonished actually. This is the end part of the thing. So again, this will be closed with the facial atom and muzzle. This is the post-op X-ray. CT scan, we showed complete decompression, complete excision of the tumor. And see the patient, there is no weakness of the extraocular movements, complete full. This is, she had sixth nerve palsy, but she has improved completely. Thank you for, okay, Dwarkanath, that is my video presentation.
Thank you, sir. Thank you for the wonderful talk. And of course, we have seen it. So I have no questions to you. Professor Goto, would you like to comment on your experience with extended transcribal approaches?
Thank you, Professor Sampasa, for nice presentation of the transcriber approach. I have just one question to the surgery of the trigeminal schwannoma, last case.
Yeah.
In case of the trigeminal schwannoma, extend to posterior fossa.
Yeah.
In such case, usually the sixth nerve, abducens nerve, push to the ventral side. So, do you have any tip to avoid the damage of the hips nerve through the endoscopic enonasal approach?
You see, I have not used any electro myography or monitoring and all. I have not used. During surgery, I felt there is little injury and all. Following surgery, patient had little abducent weakness, but she has improved over 2 weeks. That is why I finally I shown there is no deficit like that. That's
Okay.
the total excision of that tumor. See, why I used Burroll surgery, you would have seen that how much hole I have made while doing surgery. It may be hardly, it will be around 1.5 centimeters, like a Burroll only. Even I saw your keyhole surgeries and all from supratentorial. You said 3 centimeters. Is it possible to reduce further so that injury to the brain can be minimized? Like that. Here, there's no exposure of the brain, no retraction, nothing, no post-op seizures like that. If at all anything, if it is because of subarachnoid blood, it may cause seizure post-operatively. Anyway, we'll be giving prophylactic anticonvulsant for them. So what I did for this aneurysm surgery, all cases I did with the lumbar drain. So lumbar drain, which has helped because the distance between clivus and basilar artery will be widened. Otherwise, it will be very close to the dura. We may likely to injure the artery. So better to do under lumbar drain so that that can be taken out 2-3 days later. So you have seen them my post-op cases also, no? How the patients are walking and all. There's no question of deficit to say.
Thank you. If there are no further questions, I thank you all on the behalf of the NSI for this wonderful talk. Thank you, Professor Goto, for spending your precious time with us. And we hope to see you soon in India again. Thank you. And I thank Professor Sampath and my co-chair, Dr. Dandapani, for this presentation. Thank you, sir.
Thank you.
Thank you.